Okay, so good morning, everyone. In this class, we will discuss about respiratory physiology during wakefulness and how it changes during sleep. We will discuss about how ventilation is being controlled in our body. What are the area in the brain which gives signal for inspiration and how expiration usually starts. Then we will see that if brain area gives signals to our body, what are the muscles which are being affected by those areas, and how brain decides when to increase or decrease the ventilation by providing or inhibiting the signals of inspiration and exhalation. Okay, and then we will briefly touch upon the two concept in respiratory physiology. One is arousal threshold, and one is loop gain. Okay, so respiration is an active process, we all know, and exhalation is a passive process. To start inspiration, brain or central areas need to give some output to the muscles, and for exhalation usually it's just the inhibition of those inspiratory output, and thus we consider exhalation as a passive process. The tidal volume is the volume we use to inhale or exhale. In quiet breathing, means normal breathing, where we are not doing voluntary increase or decrease the depth of respiration, and it is around 500 ml. The respiratory rate normal range is 12 to 16 breaths each minute. The minute ventilation is the air we breathe in and out in a minute. So it is the tidal volume multiplied by respiratory rate, and it is around 6 liters. PaO2 and PaCO2 are the partial pressure of O2 and CO2 into our arterial blood, and the normal range for PaO2 is 67 to 104, and for PaCO2 is 35 to 45 mmHg. Okay, so this is the range what our respiratory respiratory area or system want to maintain. So this is the range where we say that this is eucapnia. Okay, so ventilatory regulation. So ventilate as I have discussed this thing already, that in we have something in our brain which is central controller, the brain areas of respiration, and then sensors which detect the changes or abnormality in the PO2 or CO2, and then effectors. Effectors are basically the group of muscles which ultimately lead to change in ventilation. Okay, so the central respiratory controller, if we talk about, there are basically three groups: pontine respiratory group, dorsal respiratory group, and ventral respiratory group of neurons, uh, which controls the respiration. It's the dorsal respiratory group of neuron, which is mainly they contain the neurons for inspiration, and the ventilatory respiratory group of neurons have gives signal for inhalation and exhalation both. And the pontine respiratory group, which was also known as pneumotaxic center, is mainly responsible for fine tuning of respiratory rhythm. Okay, So the pontine respiratory group contains nucleus parabrachialis medialis, which which has expiratory neurons, and nucleus parabrachialis lateralis, and the collicular fused nucleus contains inspiratory neuron. So it it has its role in fine tune the respiratory pattern and control the duration of inspiration. Next is dorsal respiratory group of neurons contains mainly the inspiratory neurons, and DRG also contain a very important area of neurons, nucleus tractus solitarius, which is the key cardiorespiratory sensory integration site. So NTS is the nucleus which integrate all of the information the brain gets from either peripheral chemoreceptors or the central chemoreceptors, the whole of the abnormalities, and then it this is the area which integrates and decides that what is the need of that particular moment to increase or decrease the ventilation. So it receives afferent information from lung receptor with the help of vagus nerve, the peripheral chemoreceptors with the help of glossopharyngeal nerve, and central chemoreceptors which are there in retrotrapezoid nucleus. So retrotrapezoid nucleus is the area where the central chemoreceptors are there, which senses the H plus concentration and respond, gives its afferent to the NTS, and then further decision about the respiration taken place. And NTS gives its afferent to phrenic and intercostal nerves. By phrenic nerve, we all know that which supplies to the diaphragm, and diaphragm is the main muscle of respiration in quiet breathing. And it also gives its afferent to intercostal nerves, which supplies to the accessory muscles of respiration, and thus helping in case decrease or increase in ventilation requires in accessory respiration. Okay, so ventilatory respiratory group, it contains neurons for inspiration and expiration both. The group of neurons, one is pre-Boehringer complex. It contains inspiratory neurons. It is also known as the pacemaker of respiratory system. It is the rhythm generator, as we know the SA node is the pacemaker of heart. It co-expresses mu opioid and neurokinin 1 receptor. Mu opioid actually decreases the rate. Neurokinin 1 receptor increases the respiratory rate. And mu opioid receptors are the receptor on which the opioid drugs acts and decreases the respiration. It has potential to decrease the respiration, and the maximum effect has been seen in non-REM sleep and during general anesthesia. One is Boehringer complex, which contains expiratory group of neurons. Then rostral retroambigualis, and caudal ambigualis, which contains inspiratory and expiratory group of neurons respectively. Another area is nucleus ambiguous, which is also in the VRG only. It contains the motor neurons that innervate muscles of larynx and pharynx. Okay, so the muscles of respiration apart from larynx and pharynx are supply the larynx and pharynx are supplied by nucleus ambigualis. So so the effect on muscles of larynx and pharynx during sleep is a bit different than what we see with the diaphragm, the main muscle of respiration. We will discuss this later also. Okay. Now the sensors. So we have central chemoreceptors which are there in retrotrapezoid nucleus, which is uh, there on ventrolateral surface of medulla. It senses the extracellular fluid H plus concentration and re- respond accordingly. If H plus concentration is high, then it increases the ventilation. If it is low, it decreases the ventilation accordingly. The peripheral chemoreceptors, they are there on aortic and carotid bodies, and they receives they gives its efferent via ninth and 10th cranial nerve and respond accordingly. So the central chemoreceptors are basically respond to the concentration of CO2, and for for the concentration of O2, the major response is being generated with the help of peripheral chemoreceptors. One is pulmonary mechanoreceptors, like pulmonary stretch receptors, which are located in proximal airway smooth muscle, the J receptors, and bronchial C fibers. When they are activated, they leads to rapid shallow breathing, like we see in Haring reflex, and they also gives their afferent to the central integration area with the help of vagus nerve. And upper there are some other receptors also on upper airway which promote airway patency by activation of local muscles, including genioglossus muscle. So these are the main receptor of our respiratory area. Then effectors are, as we have discussed, that these are the group of muscles which act to change for ventilation. So respiratory motor neurons like phrenic and intercostal nerves and muscles. Diaphragm is the main muscle of inspiration supplied by phrenic nerve. Then accessory muscles of respiration. And for inspiration, these are external intercostal, sternocleidomastoid, scalene, trapezius, and these are. And for expiration, intercostal muscle, abdominal muscle, clavicular head of pectoralis muscle. And there are upper airway muscles which their function is to dilate or open up the upper airway, and these are genioglossus muscle supplied by hypoglossal nerve, and transect palatine muscle which is supplied by trigeminal nerve, and sternohyoid muscle is supplied by spinal nerve, and these are pharyngeal dilatory muscles. So these are the muscles which act to increase or decrease the ventilation. Now, what happens when there is inadequate ventilation, which leads to hypoxemia or hypercapnia, and decrease in pH leads to acidosis. These abnormality being sensed by the peripheral and central chemoreceptors, and they gives their information to the central integral area, and then after integration of the information, a decision has been taken, and this impulse from respiratory center reaches to the diaphragm and intercostal muscles to either increase or decrease the rate and depth of respiration. And 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 in case of hypoxemia and hypercapnia, rate and depth will be increased, and to maintain the pH CO2 in the eucapnic range. Now, see, when we see the muscles which are being affected during rest and sleep, when one group of muscle is postural muscles, so their tone is highest in wakefulness, but decreased in non-REM sleep and minimal in REM sleep. We all know that the there will be muscular atonia in RAM, to inhibit us to enact our dreams, because the dreams in RAM sleep are very vivid, and we may act in those dreams and may harm us. So, so these muscles are, inhibited in REM sleep, and their activity decreases in non-REM sleep. Uh, Now, respiratory muscles with the respiratory and non-respiratory functions, like intercostal muscles and pharyngeal muscles, their tone actually decreases in decreases immediately when we go into sleep. So, our intercostal muscle and pharyngeal muscle tone actually decreases in sleep. Then one muscle is diaphragm, which has respiratory muscle with respiratory function only. Diaphragm does not have any other function. So the activity of diaphragm a bit decrease, but in comparison to other muscles of respiration or other body muscles, their activity is well maintained. Okay, and they spared the RAM atonia also. So as I told you previously that the muscles of larynx and pharynx are supplied by different group of neuron in comparison to diaphragm. Activity of diaphragm is spared during sleep, but activity of pharyngeal muscles are markedly decreased in sleep. Okay. At this point, I have discussed here also that phrenic motor neuron and hypoglossal motor neuron. Hypoglossal motor neuron, which supplies the with the help of hypoglossal nerve to the upper airway muscles, and phrenic motor neuron supplies diaphragm. So, inspiratory drive in phrenic motor neuron is generates from DRG and VRG, and its drive well maintained during sleep also. While the hypoglossal motor neuron receives its drive from a reticular neuron, which provides a tone to the hypoglossal muscle, and this reticular activating neurons are mainly inhibited during sleep. So the tone of hypoglossal, the muscle of upper airway well inhibited in sleep, while the tone well maintained in phrenic, in the diaphragm. And one point I have mentioned in here, that phrenic motor neuron activity inhibited in expiration. It means that when this supply of, this we have discussed, if you see the muscles of upper airway, and if you see the diaphragm, so the activity of diaphragm decreases in exhalation. This dotted line is indicating the start of inhalation. So during inhalation, there is activity, but there is no tone during exhalation. But there is tone if you see the upper airway muscles, there is a tone in the exhalation also. This I have mentioned, that the phrenic motor neuron supplies diaphragm, and its activity inhibited in exhalation, while the activity of the tone in the upper airway muscles well maintained in exhalation. Do not confuse this thing with what I have discussed previously, that the activity of hypoglossal motor neuron decreases in sleep, while this decrease in activity in spared for phrenic motor neuron or for diaphragm. What I want to give the message here is during wakefulness also. During wakefulness, the upper airway muscular tone is well maintained in exhalation, but its tone is decreased in diaphragm muscles. This is about wakefulness. Okay. So hypoglossal motor neuron activation, inspiratory drive add to the continuous chronic drive. So there there will be a drive during inhalation and exhalation, and inspiratory drive actually add on the tone which was well maintained. Okay, so this tonic drive to our upper airway muscles, which uh, leads to airway size and stiffness, it withdraws in sleep, leads to vulnerability of upper airway to collapse during sleep. Got my point? So during sleep, because the activity in upper airway muscle decreases, the tone decreases, there are chances that upper airway may lead to collapse in sleep, while the activity of diaphragm is well maintained during the sleep. Okay, position changes during sleep. So when we lie supine for sleep, our upper airway predisposed to collapse in normal individual also, not especially to OSA, but to all of us, because there is a reduction in muscle tone. There is a redundant soft tissue in upper airway, which can lead to airway compromise, like the soft palate, the you know because of decrease in traction of upper airway, because of decrease in functional residual capacity during sleep, the traction on upper airway, the stretch of weight of lung in upper airway decreases, which leads to floppy upper airway, which can be collapsed during sleep. And one thing is retroglossal narrowing, because of the fall of tongue backward because of our supine position and decrease in tone of the muscle. It leads to retroglossal narrowing. And one more thing is there is a subtle increase in vascular congestion because of moving of the blood or edema from lower limb to upper part of our body, and which can lead to slight congestion in upper airway also, and decrease and predisposes upper airway to collapse. In supine position, the effect of increased abdominal distension exceeds the effect of chest wall expansion, and thus FRC reduces, because the when we lie down, the all of our abdominal content pushes slightly upward towards diaphragm, and the because the muscles of chest wall also, the tone in them decreases, so the elastic recoil also a bit decreases, and thus there is a possibility of decrease. There is FRC, functional residual capacity reduced. What is FRC? FRC is functional residual capacity is the volume of air remained after quiet exhalation. After when we normally exhale out, during exhalation, the volume of air exhaled out, still there, the volume of air remained in the lung is functional residual capacity. So it depends on how much space is there uh, for the lung to be remained in the expanded position. So if the space decreases because of because of push of abdominal content upward towards diaphragm, or because of decrease of elastic recoil, or because of some extra blood in the lung because of our supine position and movement of blood from lower limb to upper part of our body, this FRC reduces. And the reduction in FRC is also an important cause of decreased traction in upper airway during sleep. With REM sleep associated atonia, skeletal muscles associated with respiration are significantly impaired, and ventilation is accomplished by diaphragm alone. And the chest wall compliance, because the muscles of chest wall are also relaxed, the compliance is increased, and a paradoxical collapse of chest during inspiration may occur. What is point? Because during inspiration, because of activity of diaphragm, and because if we are using our intercostal muscles also, they work in a way to increase the volume of chest. So the chest will move upward and outward during inspiration. But if the tone of the chest wall muscles reduces significantly, and when the diaphragm moves downward during inspiration, there will be a pressure, a negative pressure on chest wall, and there might be a collapse or indrawing of chest wall during inspiration in sleep. Okay. Now we will see the input to breathing during wakefulness and sleep. So if you can see, we have discussed the peripheral and central chemoreceptors, the mechanoreceptors in the lung, which gives their input and you know affected the breathing. We have wakefulness drive to breathe also during the wakefulness, and we have a voluntary control on breathing also from our higher brain centers. And one more thing is receptor for our sensory receptors for touch, temperature, and pain. They can also affect our breathing rate. These all works during wakefulness in affecting the ventilation, but during sleep, because now we are sleepy, our voluntary control completely our breathing completely inhibited, our emotional stimuli affecting our ventilation country completely inhibited, and our wakefulness drive during breathing is also completely inhibited during sleep. And the um, the effect of proprioceptors, sensory receptors, and mechanoreceptors also decreases during sleep. So During sleep, the main input to breathing is our chemoreceptors only. Okay, so we are completely dependent on uh, the sensitivity of these receptors during sleep. You know, that is why the the patients who are already compromised in their ventilation, maybe because of any restrictive lung disease or obstructive lung disease, which are uh, very much dependent on the wakefulness, uh, drive to breathe, and voluntary control of breathing. They are affected more during uh, during sleep, because the just because of the chemoreceptors, the response is inadequate in them during wakefulness, and same has been seen during the sleep also. So they are more vulnerable to ventilatory uh, failure or inadequacy during sleep. Now, what happens during sleep onset? So, wakefulness, drive to breathe, and other influences decreases or completely abolished with sleep onset. Movement and excitatory input to breathe from external sensors like mechanoreceptor or sensory inputs, they are also decreased or completely absent during sleep, the sleep onset, and the chemoreceptors are only active during sleep, but their activity also decreases during sleep. Uh, so the respiratory muscle tone is reduced, which leads to decrease in minute ventilation, because we have discussed that the activity of respiratory muscles also decreases during sleep, and the upper airway muscles tone is also decreased during sleep, leads to upper airway resistance, and thus decreases the minute ventilation. It has been seen that upper airway resistance is increased up to 230% during sleep. Hypercapnic and hypoxemic ventilatory responses, if you see that these the let us discuss hypercapnic ventilatory response first. So hypercapnic response we can see with the help of slope of the response and resting ventilatory set point. Resting ventilatory set point is the level of CO2 above which ventilation increases. Okay, so this is the point up to what body can, body accept the level of the CO2 and consider it as a state of eupnea. So this resting ventilatory set point shifts towards right side in the sleep. It means about hypercapnic. We were discussing about hypercapnic and hypoxemic ventilatory response. So in hypercapnic ventilatory response, the resting ventilatory head point or the level of CO2, which will be considered as eucapnia, shifted right side, means the this point will be uh, at a higher level of PCO2, and the slope of ventilatory response also decreases in sleep. It means that the response will be decreased in sleep and maximum in REM sleep. Same thing happens with the hypoxemic ventilatory response also. that during sleep, the slope of the response decreases, the level of uh, abnormality will be accepted by the body more. Okay, and it has been seen that there are gender differences in this response. Women usually preserve the awake responses, hypoxemic and hypercapnic, both during non-REM sleep. But in REM sleep, there has been no gender differences in as far as response is concerned. In stable sleep, because the control of breathing becomes dominated by the chemical input only, and we have discussed that the response for hypoxemia and hypercapnia both decreases, but response to hypoxemia decreases more than hypercapnia. Even it has been seen that during sleep, the decrease in SpO2 up to 70% has been well tolerated by the body in comparison to hypercapnia, which if even if increase of 15 mmHg, it leads to arousal. Okay, so response to hypoxemia, hypercapnia both decreases, but this decrease is lesser for hypercapnia. That's why the PCO2 is the main determinant of ventilation during sleep. And as we have discussed that minute ventilation decreases, and it decreases up to 1 to 2 liters each minute in sleep, and the PaCO2 increases to 3 to 8 mmHg during stable sleep compared to wakefulness. And this is because shift of that resting set point also. Okay. Airway resistance increases in sleep. Lung volume, we have discussed that FRC decreases during sleep up to 200 to 500 ml, and because of reduced chest wall and lung compliance, accumulated intrathoracic blood volume, and relative hypotonia of diaphragm. And minute ventilation, because tidal volume also uh, reduces in sleep. This reduction is more in REM sleep in comparison to non-REM, and the values are 25% in REM and 6 to 16% decrease in tidal volume during non-REM sleep. The respiratory rate increases slightly. So with decrease of tidal volume, increase in respiratory rate leads to rapid shallow breathing, and this is most prominently seen in REM sleep. And minute ventilation reduce more in REM sleep than non-REM sleep. Now, what happens during arousals? So, as we all know that 10 to 20 times arousals are also seen in healthy subjects, and this frequency increases with age. They can be because of spontaneous or because of any respiratory or movement disorder or event. And we have discussed that for arousal, hypoxia is poor stimulus. Body can tolerate much severe hypoxemia than hypercapnia. So hypercapnia and the response as arousal is more with hypercapnia than hypoxemia, and this arousal also affected by increase in upper airway resistance and airway occlusion uh, during non-REM and REM sleep, but lowest in N3 sleep, N3 sleep of non-REM sleep. Okay, now ventilatory response to arousal. What happens with ventilation during arousal? So with arousal, the wakefulness chemical control of breathing is reinstated. The drive is reinstated, and the because the set point of PCO2 also shifted, towards lower level of CO2 now. This the level of CO2 which was normal during sleep is now very high during wakefulness. So ventilation increases, and this increase in respiration comes with the increase in respiratory rate and depth both. Effect of arousal is beneficial and harmful both. Beneficial because it resolve the blood gas disturbances and alleviate the work of breathing rapidly. Harmful because if the arousal is too frequent with the lesser amount of response, sorry, the disturbances, then it may destabilize the ventilation, because during arousal there will be hyperventilation and hypocapnia, and when the patient goes into sleep, suddenly this hypocapnia will go towards will leads to apnea to normalize the level of PaCO2 now. And if these disturbances happen again, it leads to arousal, and thus the threshold of arousal is very important. If it is low, then it can destabilizes the ventilation. The patient will move from hyperventilation to hyperventilation frequently. Okay. Now the point is about arousal threshold. So arousal threshold is, around one third to half of the OSA patients wake up to very small changes of around 15 centimeter S2 in negative intrathoracic pressure, and it is a low respiratory arousal threshold, and this low threshold may lead or may increase the OSA frequency in non-obese people. How? Because deep sleep has higher upper airway muscle activity and stability of sleep, and low arousal threshold prevents this deeper sleep. Thus, uh, decreases the activity of upper airway muscle. Level of respiratory stimuli required to adequately recruit upper airway dilator muscles is similar to trigger arousal. The when the respiratory drive keep increasing in the event of upper airway obstruction, either hypopnea or apnea, this respiratory the level of more negative drive at one level, it can lead to arousal, or that is the area around which the upper airway muscles activity resumed. So if the arousal threshold is low, so lesser negative pressure in terms of respiratory drive may lead to arousal, and thus the it you know it doesn't allow the respiratory muscle to recruit and work effectively even during the sleep. So it's not that good to have low arousal threshold. And arousal, it leads to increase in minute ventilation, and this frequent change in minute ventilation during sleep and arousal lead to ventilatory instability. So now the last point of our class, the concept of loop gain. Loop gain, it denotes our overall sensitivity of ventilatory control system, and um, this ventilatory control system, it has three gains or parts. One is controller gain, the central area which assesses the abnormality in blood gases and respond accordingly. And its gain can be denoted by change in ventilation for a particular change in PaCO2. So if the change in minute ventilation, because it's the area in the brain which decides the rate and depth of the respiration, which in turn leads to minute ventilation. Okay, so if there is abnormality in blood gas or CO2 mainly, the ventilation will be affected definitely. But the amount of increase or decrease in ventilation in response to decrease or increase in uh, blood gas abnormality is the controller gain. So if it is high, it leads to hyper responsiveness in terms of minute ventilation with the with a small change in blood gas abnormality. Now, next is plantar gain. Plantar gain is our effector area, mainly the lungs and muscles. So it is the effectiveness of CO2 excretion from such ventilatory response. Uh, because of an abnormality in blood gas, the central area gives instruction to modulate minute ventilation or alveolar ventilation. With the help of that input from the brain to the muscles and lungs, how much CO2 it can excrete now. So, so the change in PaCO2 for a given change in minute ventilation. If the change is high, then there will be instability or higher loop gain. But the point, if the brain gives a signal to increase the ventilation in response to hypercapnia, but if the changes in CO2 is higher for that much amount of instruction for minute ventilation, it leads to uh, hyperventilation and hypocapnia further. One thing is mixing gain. Mixing gain is the time period it takes from the information from the peripheral area, mainly from the lung, to the brain. If the blood flow is sluggish, or in case of shock, then mixing gain will be increased. Why? Because now it will take more time of this change in CO2 level, either hypocapnia or hypercapnia. This information will reach to the brain late in comparison to what the time it should be. So mixing gain also affected our uh, ventilation overall control. As we can see here, the lungs and the muscles makes the plantar gain. The area in the brain is controller gain, and the blood flow from information from the lungs to the brain, the time period required is mixing gain. Okay. Okay, so if you want to see overall, if you if, if you mix the plant gain, controller gain, and mixing gain, it is the ventilatory response. So loop gain is ventilatory response divided by ventilatory disturbance. If the disturbance, the response is equal to the disturbance, then loop gain will be 1, and it is the ideal condition when the ventilation is stable. E- Even if the loop gain is low, means the response is slightly lower, then the disturbance is stabilizes the ventilation system. But if the loop gain is high, when the ventilatory response is higher than the ventilatory disturbance, it leads to instability in ventilatory system. How come? Because the disturbance is low. Maybe hypercapnia is a ventilatory disturbance. If the amount of hypercapnia is low in in comparison to the increase in minute ventilation, what happened because of this disturbance? It leads to hyperventilation and hypocapnia later on. So now hypercapnia leads to hyperventilation and thus hypocapnia. And now this hypocapnia becomes a disturbance now. And if the loop gain is high, the ventilatory response is higher. This amount of hypocapnia will lead to higher ventilatory response in terms of apnea, leads to hypercapnia. So a patient will hope from hypercapnia to hypocapnia to hypocapnia like this, and this ventilatory response will be higher, and this is an unstable ventilatory system. What are the factors affecting the different gains? So the controller gain, it affected by sensitivity of the chemoreceptors to the changes in the gases, the sensitivity of the integral area, then excitability and integrity of lower motor neurons supplying the respiratory muscle. Plant gain affected by respiratory cycle frequency, VQ mismatch, ventilation profile mismatch. If the ventilation is there but no blood flow in that area, it leads to mismatching. And one thing is dead space ventilation. If it is increased or decreased, it also affect plant gain. And mixing gain affected by circulatory delay time, thoracic blood volume, and brain extracellular fluid volume. It affects the time required to reach the information from lungs to brain. Okay, so just to summarize, most of the stimulus for breathing are either diminished or absent during sleep, except the chemoreceptors, though the response to hypoxemia and hypercapnia both decrease during sleep, but the still response for hypercapnia is higher than hypoxemia. So the CO2 is the main modifier of ventilatory control during sleep. Minute ventilation decreases during sleep more in REM than non-REM, and REM is associated with rapid shallow breathing more in comparison to non-REM. Thank you very much for the patient listening and bear me. Now the meeting is open for discussion.
Sir,
Yeah,
sir, I wanted to know whether, so you talked about this chemosensitivity as the primary driving force for respiration during sleep.
right,
Uh, Other thing is there is also you talked about tonic respiratory tonic input which maintains throughout, and there is this phasic input which occurs in bursts. Now
right,
as far as I understand from our books, the tonic input is the non-respiratory input that they are telling, and phasic input is the respiratory input that they
right.
have mentioned in the neurons.
Mhm.
Now, this tonic input is maintained, if it is maintained during sleep, then it adds to the chemosensitivity input also, or the tonic input really decreases. Uh,
See,
so
the tonic input decreases in sleep. That is why our upper airway muscles and the tone decreases in sleep. And
okay.
when we say that chemo
Mm,
sensitivity is the main stimulus
right, sir.
or the main sensitivity in sleep, we talk uh, about the other effectors like wakefulness drive, voluntary
Mm,
control, emotional
mm,
stimuli,
mm,
mechanoreceptors, their activity completely abolished, decreased, or completely
mm,
abolished with sleep. So now ventilation is dependent on chemosensitivity or receptors only. This,
mm,
this is what we were discussing. Now,
mm.
during the wakefulness, because of hypoxemia and hypercapnia, a patient can increase his respiration rate and depth voluntarily also.
Right,
Okay,
right.
but during sleep, this voluntary control and other controls are
Mm,
uh, inhibited. So now, if there is, the hypoxemia and hypercapnia will be dealt by the receptors only,
right, sir.
the
So,
chemoreceptors only.
yeah. So, sir, then my question comes that whether this tonic input and phasic input to the
Mhm.
respiratory motor neurons, is it limited to the upper airway muscles, or is it generalized to diaphragm, the main respiratory muscle
See,
site?
the tonic input decreases overall. Okay,
Okay.
but because diaphragm does not have any tone in
Mm,
exhalation, so diaphragm, the activity of diaphragm is not much affected with this
right, sir.
tonic drive,
Okay.
right?
Right.
And
So, I
inspiratory
think,
inspiratory input is already there
right, sir.
during inspiration, so the activity of diaphragm is not much affected
But
during sleep.
I think that these inputs, the tonic and phasic ones, are more restricted towards the upper airway muscles, probably. If
I think
Because
the not only upper airway muscle,
the
if
other
we talk about
accessory muscles.
the, yeah,
Yeah.
accessory muscles also, so their tone is also decreased
Yes.
during sleep. That is why the chest become floppy, and
Right, sir.
because of negative pressure,
Mm.
intrapleural pressure, there has been seen paradoxical in drawing of the chest during inspiration also.
Right, sir.
So upper airway and these accessory muscles of
Mm.
respiration also are affected during sleep.
But the chemosensitivity drive definitely affects diaphragm, probably.
Um, See,
Mm.
these central and peripheral receptors are basically receptors which take input from blood and
Yes.
they give their afferent to the brain, and from
Right.
brain the motor neuron come to muscles.
Mm.
So saying that these chemoreceptors affected the diaphragm directly will not be a good thing, because
Mm.
their work is just to assess the abnormality and give afferent to the brain,
No, sir,
right?
what I am concerned about is that during sleep, we have
Mhm.
this, the main muscle that maintains our respiration is diaphragm,
Right,
generally.
right.
Now, which are the inputs that significantly affect this diaphragmatic tone or diaphragmatic drive? Which are
Mhm.
so whether because we are seeing that we're talking about gains and yeah, arousal thresholds. So
Mhm.
those definitely they cause apnea. The ventilatory overshoots, they cause apnea. during awakening and all these things. So when they are causing apnea, it means that the diaphragm is also at rest at that point of time. Diaphragm is not actively having participation in respiration. So probably that this mean what I could deduce is that this means that the chemosensitivity reflexes actually affect diaphragm, or this is what I could deduce, because the chapter is, these are a huge chapters, so it is very difficult to understand which drive, which are the drives that they are telling that this affect the upper neurons or this affect the accessory muscle neurons. It is very difficult to comprehend.
Okay,
So,
okay, got your point.
so
Right. Any other questions? Okay, so if there are no more questions, we conclude our class here only.